Right, well, for everybody who has joined on time, warm appreciation and thanks for that. We are joined this evening, very, very graciously joined this evening by Dr. Grace Park, who is the Regional Medical Director for MAiD, and her colleague Tammy Dyson, who is the leader for MAiD. We're very happy to have them and also acknowledge that we are joining you today, or at least myself anyways. Dr. Park is joining us from somewhere different, but I'm joining from the shared and unceded traditional territory of the Coast Salish peoples, in which I'm honored to work, play, and learn. So I will happily hand it over to Dr. Grace Park and Tammy Dyson to share their knowledge with you. A small piece of housekeeping, I'm sure everybody knows this already, but do keep your microphone off while Dr. Park and Tammy are speaking. It's a casual conversation this evening, so feel free, if you have questions, use the chat function. There's that raise your hand option if you wanted to ask a question. I'll be moderating the chat box. If you had some comments, there'll definitely be opportunities to share and talk amongst each other and ask questions. So please feel free to use those two options. If you are so comfortable, please feel free to turn your camera on. We love to see your faces and interact with all of you. I do know Zoom fatigue is a real thing, however, so if you want to have your cameras off, that's also totally fine as well. So on that note, I'm happy to hand it over to and introduce Dr. Grace Park and Tammy Dyson to you all this evening.
Hello, everyone. Thanks for joining us. I'm just going to share my screen. Okay, great. So Tammy and I will be talking this evening around some of the updates regarding medical assistance in dying, and then we'll do a couple of case presentations at the end. And hoping to have a discussion because these are very controversial topics, and it would be really nice to get your thoughts and your input. And mostly we're trying to make it comfortable for you with the knowledge so that you can actually provide assessments for your patients when they ask you about MAiD, and to be able to have meaningful conversations at end of life with your patients. So just before we get going with all of that, let me see if I can get my computer to work here. There. A little bit of statistics since we started. This is 2016 to 2019. Canadian data showed we had 13,000 reported MAiD deaths. And the profile is average age of about 75 years, approximately the same number of males to females. Most common underlying condition was cancer of 67% of total cases. And then the rest were neurological conditions and end organ diseases, cardiovascular and respiratory conditions. And there were, in 2019, approximately 1.89% of all total deaths in Canada were by MAiD. So the numbers were at close to 2% at that time. And we know from other countries that have been providing MAiD over the last couple of decades, the numbers vary from 0.3% to 4.6% of all deaths in those countries are by MAiD. And so it is something that we are seeing more and more of. And there's been a gradual increase over the years in the 3 years these numbers show. And then these are numbers in Fraser Health. And since the beginning of MAiD in Fraser in 2016, we had almost 2,500 cases of applications coming forward. And of those, 1,340 MAiD deaths were provided. And we had some that deteriorated out of eligibility. As you know, people had to give that final consent. And if their health declined, they were not able to get the MAiD. And so that was that. And some died naturally. And then there were a few that were not eligible, etc. So we get more cases of application than actual cases of MAiD deaths. And when you look at the tables on the right-hand side here, and we see the total percentage of deaths. So in Fraser Health, 2019 to 2021, you see the number of MAiD deaths gradually going up, and then the total number of deaths in Fraser. So in 2021, 2.57% of deaths in Fraser were by MAiD. And then when you look at total BC, in 2021, 4.6% of total deaths were by MAiD. And then breaking it down by health authorities, as you know, Island Health has always been the highest in terms of number of MAiDs provided. And with the same number of people serviced by the Vancouver Island Health Authority, they do more than about 2.5 times more MAiD deaths than Fraser. And so total So the total in the Island Health was 2,700 and Fraser was 1,200. And then in total in BC was 7,300. And that was from the January 1st, 2016 to March of 22. So those are current numbers actually. Okay, so then we'll move on. And just a quick overview of the eligibility criteria as set out in June 2016. That was Bill C-14, the very first bill that was there. So they had to be eligible for Canadian public funded health services. So we were not going to have people coming in from other countries just to access MAiD. They had to be 18 years of age, capable of making healthcare decisions, have a grievous and irremediable medical condition. They had to have a voluntary request, and they had to be informed of their diagnoses, available forms of treatment, and options to relieve suffering, including palliative care. So those were the eligibility criteria. And then the grievous and irremediable, which is not really a medical terminology, was explained further. And in order to have the grievous and irremediable, they had to have a serious and incurable illness or disability. They needed to be in an advanced state of irreversible decline in capabilities, enduring physical or psychological suffering that is intolerable to the person, and that natural death has become reasonably foreseeable. So natural death foreseeable near future was the piece that came into question for Bill C-7. And so Bill C-7 came into effect in March of 2021. And that basically removed that requirement of person's natural death being reasonably foreseeable. It also allowed people with sole underlying medical conditions, being mental illness, to be applicable, to be eligible for MAiD, but it was going to be eligible after 2 years of consideration for development of further safeguards. And then there were 2 sets of safeguards. So we had those with reasonably foreseeable deaths and those with no reasonably foreseeable deaths, and 2 sets of safeguards that were created. And the Bill C-7 also allowed for those who lost capacity near the end of life. So with those that had reasonably foreseeable death, were able to choose a date they wished to have the MAiD. They were able to sign a form that we're calling waiver of final consent, which is not really a waiver, but an agreement with the provider that even if they lost capacity towards the end, given that it was to be in the near future, they're choosing a date, they have reasonable foreseeable death, they can actually ask the provider to proceed, even if they were not able to provide that final consent. And then there was another bit that if they were self-administering an oral concoction, if they were not successful with the oral concoction, they were giving the provider the ability to go ahead with the intravenous method. So we basically had 2 tracks made available with Bill C-7. So reasonably foreseeable natural death, they had the right to waive that final consent. They did not need to have that capacity, and if they were in delirium, they could actually give the provider the ability to go ahead and do that. And then the 10-day reflection period that we used to have has been also repealed. And so people that want to set a date now, they can have it tomorrow if they wish. They do not have to have that 10-day reflection period. And then those with no reasonably foreseeable natural death, they have new safeguards in place. They have to have a 90-day reflection period that begins with the assessment, the first assessment. And then one of the assessors needs to be an expert on the condition that the patient is suffering from. And if neither of the 2 assessors are considered experts, then they need to get an expert consultation. And then the mental health as a sole underlying condition will come into effect in March of next year, because that's when the 2-year deliberation process will end. So we have the tracks 1 and 2, and just briefly on the left-hand column is track 1. So you've got somebody with reasonable, foreseeable, and after death, the ones that we've seen all along since the beginning. Most of them have cancers, end organ disease, etc. They have grievous and irreversible condition. Their suffering is intolerable. They now have no reflection period. That 10 days is gone. They still need the 2 assessors, and they have the right to waive the final consent if they are no longer able to give consent at the time of the provision. And so that's all in place. And then the MAiD Care Coordination Center follows them during the assessment period, as well as book the final provision, coordinates all the people that need to be there, and then the MAiD provision happens. And then track 2 on the right-hand side, for those with no reasonable foreseeable death, they still have to have a grievous and irremediable condition, which means they are in an advanced state of irreversible decline, and they still have the intolerable suffering. But they have to have a 90-day reflection period. They still need the 2 assessors, but one of the assessors needs to be an expert. And if they're not, then they need to get a consultation with an expert. And all that has to happen during that 90-day reflection period. And then during that period, they need to be offered counseling services if required, and certainly palliative care as well. And then with the expert consultation, it's not their expert opinion as to whether this person qualifies for MAiD, but that this person has been offered everything there is to offer to maximize their quality of life and provide them with treatment that's acceptable to the patient. So that's what the expert consultation is about. And once all of that's done, so after the 90 days, so on the 91st day, that is the first available date for the MAiD to happen, and the MAiD Care Coordination Center organizes all of that again, and then the MAiD provision happens. So a little bit more involved on track 2, lots of moving pieces, but thankfully we only have about 3 or 4% of our total cases in the province that are actually on track 2. So we still have majority of our cases on track 1. So the role of the MAiD Coordination Care Center, I'm going to hand this over to Tammy because she has the coordination center, and as the lead for Fraser is really very involved in organizing all of the coordination that happens and connecting with all of the sites throughout Fraser. So Tammy, do you want to just take over from here, and I'll do the slides for you?
Yeah, great. Thank you, Grace. So yes, with the MAiD Care Coordination Center, some of you may have contacted us before. We're Monday to Friday. We're really the linchpin between the public care providers and to guide that process around legislation. So part of that certainly does coordinate the requests between that person who's requesting MAiD and all the different teams that are involved. There are sometimes people will phone and they're not as well connected to other programs, so we can certainly play a role with that as well. A lot of times people will just call and they'll just ask us just lots of questions. Like, my patient has requested MAiD and I don't really know where to start. So we can certainly respond to questions that practitioners may have. And of course, certainly guiding that process that is in line with the federal and provincial legislation and the requirements. I do want to say there's actually back on the earlier slide that Grace had shown some statistics. And there was over 200 people have their request on hold. So the 200 are people that have made that request for MAiD, but they don't want to proceed right away. So, and maybe some of you have had patients where they just take a lot of comfort just knowing that that's in place if and when they would want to proceed. So a lot of that too is the role that we can play is supporting people that that have the request on hold. Next slide, Grace. Yeah, so a lot of times people just say, my patient's requested MAiD and what do I do? So there is a Fraser Health MAiD brochure that can be found on our website. So that can certainly be provided. There's also the specific request for MAiD form. So that is a provincial form. So anyone who's requesting MAiD, no matter where you are in the province, it is the same form. It's 2 to 3 pages, depending on if it's large print or not. And we always encourage one to download that from the Ministry of Health website so that you are offering your patient the most current form. And that form does need to be witnessed by one person. It might be someone who's just wanting more information about MAiD. There might be someone who you're talking with that just wants MAiD right now as soon as possible. So certainly using your judgment around what would be the best information to provide, and then of course connecting with our program as well at the MAiD Care Coordination Center.
So the MAiD form can be downloaded from the Ministry of Health website, but I think it's also available on Pathways. If you just put on the search bar MAiD assessment form, I think they're uploaded there. It's also available on the Fraser Health website, which you probably don't go to. So Ministry of Health or Pathways website would be good. It all starts with a patient record or request record, and that's that first form that the patient fills out, as Tammy was saying, that needs to be witnessed by somebody. And it can be somebody, in the office, or it can be somebody, a neighbor or some friend. As long as they're not mentioned in the will, have nothing to gain from the patient having MAiD, they can witness the form. And if there's no available witness, we used to have a lot of people in that boat. We can get a volunteer from Dying with Dignity to be a witness as well for them if you've got somebody who really has no contacts. Yeah, so that's that. And then the MAiD Care Coordination Center really is the place where you go to with all your questions, and they just are so supportive and help you every step of the way. So that sort of is a very brief background. And if we just go through a couple of cases, I think we'll bring up some highlights of the new legislation and see if we can get some discussions and questions going. So this is a case of a patient with no reasonably foreseeable natural death. So this is Mr. M. He's 77 years old, and amongst the case conditions that are identified as reason for his request for MAiD are frailty and other multiple comorbidities. He suffers from pain and struggles with activities of daily living at home. He requested MAiD in August of 2021 with his GP, who's his MRP in the community, has known Mr. M for greater than 10 years, and did complete his assessment in September of 2021. So the patient was approved on track 2 with having a history of head injuries with multiple post-concussion syndromes and continuing severe neck pain due to degenerative disc disease. He had chronic unsteadiness, and it was intolerant of pain medications, and referrals to pain clinic led to limited options for him. So there was limited options that were acceptable to him. He continued to suffer. So he had reached an advanced state of irreversible decline, and he also had intolerable suffering. The prescriber, the second assessor, was arranged through the MAiD Coordination Center and did the assessment in September as well, and approved Mr. M as having a non-reasonably foreseeable natural death, and was on track 2 for cases of severe spinal degeneration, chronic pain, increasing frailty, and post-concussion syndromes. So the GP assessment, August 16th, okay, so it said 21 September, but actually it was August 16th. So the first clear day after a 90-day reflection period was November 15th. So that's one day after the 90-day reflection. So it's actually the 91st day. So it could be booked as of any time after November 15th. The GP identified himself as the expert of spinal degeneration and chronic pain, so did not require another consultation. And experts do not need to be specialists. They can be anyone, a physician who, or an NP who has experience with dealing with these conditions and can be considered as an expert. So Mr. M speaks with the coordination center and was relieved that the MAiD process was in place, and that he had more control over the end of his life, and that he could tolerate the bad days now that he had this in place. He had some family functions to look forward to in the spring, and so he wanted to put his MAiD date on hold. So we're holding on to this case until he reaches a state where he wants to set a date when he feels that he's ready to go. So this is sometimes the case where people want to have the paperwork done, but they don't want to set a date. And we have to weigh the balance of, are they suffering intolerably now? Do they have a advanced state of irreversible decline such that they wish to proceed with MAiD? And we do know that there is fear of future suffering also in the picture. So in a lot of these cases, we'll do the paperwork, but the date will be set when the patient feels they're ready. And so those are some of the cases that Tammy was talking about where we have them on hold. Do we have any questions at this point about this, or any case that you might have of patients that might be suffering from a chronic condition that's not life-threatening?
There's nothing in the chat just yet, but if someone wants to type it in, or feel free to unmute yourself if you have something you'd like to share.
Is there a time limit for the holding of this this process?
So an assessment does not expire per se. If a person has requested it and we haven't heard from them over a period of time, we usually as providers will check back. So if I have a case and I know a person has said they want to put it on hold, in 3 months' time, I'll check back with them to see what's going on with them. And I have a lot of cases with people with dementia that I check back even, every couple of months to see how they're doing. And if they're starting to decline, then I'll see them a little bit more frequently. But it doesn't necessarily expire, but you just need to update and ensure that the person is meeting all criteria.
You still need to have 2 assessors do that, or you just sort of update it with one person?
I think most assessors would feel comfortable touching base with the patient again, given that they may have had some time lapse since they last spoke with the patient. But there is nothing, in the legislation that says that you have to go back or you have to update or refresh, and the assessments do not necessarily expire, but as clinicians, we would update the cases.
And that's true for both RFND and the non-RFND as well. And there are times that people will phone us and we've had their request on hold for a year. And as Grace says, it's often the prescriber that will reach back and say, what's been going on in the last year and how is one doing? Only if there's been a significant change in condition have I seen that there's been another assessment that's been requested by the prescriber, but that's with a significant change in condition.
And then there are cases where I feel that really the patient is not ready to make a request for MAiD. They're just trying to gather information. And I might not submit the assessment form yet. I'll just hang on to it. I had one lady who was really happy in her new retirement home and was looking forward to her grandson's graduation. And she was really having a good time at her new place. And the socializing was really improving her quality of life. And so I did tell her, I thought that I think you're having a really good time here, and maybe we ought to wait. And, I'll check back with you in a few months and see if you still wish to proceed with assisted dying, but maybe things have changed in your new environment. And she said, okay, well, I'm sorry I wasted your time, but, and she agreed. Really, she did not wish to proceed with assisted dying, but she really wanted to find out what that was all about. And the request may have come before she moved into an assisted living condition, as a situation where she was having a better quality of life. So all of these things are things that you would talk about with your patients that you know so well. So keep thinking about that, and I'll move on to the next case that we've got. So this is in anticipation for March of next year, when underlying medical health conditions can be the sole reason that they're requesting MAiD. So this case came out of Royal Columbian Hospital just recently. A 26-year-old male who was in good physical health and no history of psychiatric conditions presented himself to emergency, stating that he had quit his job recently. He was working as a software salesperson and was in the sale of cryptocurrency, he was doing very well, but he had these beliefs that there was a chip in his brain and he was being followed by famous politicians and wealthy people. And they were actually chasing him down, and I don't know what they were actually chasing him for, but they were actually making his life kind of uncomfortable, and he wanted to find out about MAiD. And he came into emergency actually requesting to speak to a mental health worker regarding MAiD. So he got referred to a mental health outpatient program, community mental health, for self-referral, and the physician that saw him there thought the delusions were quite fixed and that he really should be getting inpatient treatment, so was admitted to the mental health unit at Royal Columbian Hospital. And there it was again noted that he had these fixed delusions, that there were people coming after him, knew of his whereabouts due to the chip in his brain, and that he was wanting to have MAiD if these people continue to come after him, but he wasn't quite ready to set the date. But he did agree to treatment, and so they started him on some medications and was admitted for a period of number of days. And he gradually settled a little bit, that thinking that he might go to some outpatient mental health follow-up visits, and got connected to the EPI program. And so, as being no longer not a risk of harm to himself or others, he was discharged home and followed up in the community. So this fella did not have any medical conditions, certainly did not have any previous intolerable medical conditions. He was in good health physically, and he solely had a medical condition, and he was coming forward and requesting MAiD because he knew about MAiD, and he knew about March as being the time that he could become eligible for MAiD for next year. And so with this condition, with this situation, we got him the help that we would for any situation, got a psychiatrist involved who was willing to speak to him about his delusions and about his delusions that were driving his MAiD request, and that he could be helped by the medications and by interventions, that maybe he will not feel this way, for much longer, hopefully, and that then he would need to have the MAiD. And so this is the way it was going to go. And luckily he got the assessment and the consultation fairly quickly, because he was articulate enough and compliant enough. He came into emergency, proceeded with the recommendation to apply for or contact the community mental health program, and got to see the psychiatrist, came in on a voluntary admission, was treated with antipsychotics, and will follow up through the EPI program. But we will have a lot of other conditions that won't be as straightforward, will not necessarily get the medical psychiatric consultation in such a timely manner, that we will have to deal with in the community. And in countries where they've had MAiD with psychiatric conditions for a long time, like the Netherlands and Belgium, they show that personality disorders are the commonest ones, followed by affective disorders. So it's going to be a challenge when you've got people with mental health conditions and they're coming forward. It's going to be a challenge from, trying to ascertain whether they're actively suicidal, and do we get help for them, and can we get them help in a timely way? Or are they coming forward with a long-standing personality disorder, and now they're wanting to have MAiD because they're eligible? And then how do we get them the psychiatric consultation and support from the mental health team in a way that is going to help them, so that they don't go forward and start requesting MAiD and going down that path. So there's a lot of work going on right now. There was a list of recommendations that came forward from the consultation and the report that was developed by the federal consultation process. And then between now and March of next year, hopefully we'll have some safeguards that are actually recommended for the provinces to follow. Otherwise, we're trying to build, supports and build mental health and social work kind of supports for people, so that we can actually help those that wish to have other help. It may be social determinants of health that need to be addressed, rather than straightforward requests for MAiD. So this is a lot of work that's going on right now in the health authority and in the province. So any thoughts on that? And this is just a list of helpful links. And I'm going to make the slide deck available through April. So I'm going to stop sharing, and maybe we'll just go back to the cases and see if anybody has other thoughts, questions to ask. We do have cases of patients with osteoarthritis coming forward and requesting MAiD. We've always had patients with spinal stenosis coming forward with requests for MAiD, but now we'll see it with degenerative joints of all sorts. And other end organ conditions where we wouldn't have necessarily thought that they're on a trajectory to natural death. So it's going to be difficult with the non-reasonably foreseeable death group. So I'll stop sharing and see if anybody has any questions. Welcome any thoughts. We can be controversial. You can throw out whatever you're thinking about MAiD in general, because we always learn from people thinking differently. And if you have any questions.
If there's not any questions, Grace, I'm wondering if you might be able to comment around how people might be able to bring this up with their patient. I know that's several questions that we get on our end, which they're not quite sure if their patient is something that they might be interested in, and around the timing and how to bring this up.
Mm-hmm. Yeah, it was always a challenge to say, can we bring this up to people when they're suffering, clearly suffering, and maybe they are not aware of MAiD or their ability to request MAiD. But now we're including MAiD as a discussion for end of life. And that's why we're in the series, with your learnings in the last session around end of life, advanced care planning, etc. So we're recommending that this be part of the discussion around end of life when things become pretty painful and intolerable suffering is setting in. You could talk about palliative care. You can talk about end of life pain management. What kind of supports are in place to improve their suffering, their symptom management. And then you could talk about MAiD along that spectrum of services that are available to them. And, if you talk about palliative sedation as a way of, ending intolerable pain, you could talk about MAiD as a way of choosing when you wish to end your life. That can be part of the discussion. I guess it depends on your relationship and when you feel a person has reached that point and whether they really truly do not know that there is MAiD, then you could give them the information if there has been a bit of a discussion to start with around ways of reducing suffering. So that's usually how I couch that. Does requests for MAiD always have to be initiated by the patient? The request for MAiD has to be yes, but the topic can be brought up by yourself, as an offering of a way of reducing suffering, of ending suffering. If they start making comments about wish to end their lives or making comments about their life not being worth living, you could talk about, pain management, symptom management. And if you really do need to talk about end of life wishes, then, do you wish to end your life? There is medical assistance in dying. There's lots to learn about that, and we can talk about that. So that could be a way of doing that. But so you can initiate the conversation, but the request has to come from the patient. So the form has to come from the patient. Hope that answers the question. If you have any other, if you want to elaborate on that question, Dr. Kumar, I'd be happy to take more. Okay, so you guys are all being shy. You can just turn on your mic here. 67-year-old female with disabling Parkinson's. They've exhausted all resources. Yes, and that definitely would be a case and similar to cases that we're seeing. We're seeing a lot of patients with Parkinson's, MS, and certainly ALS, and they've always been eligible. And now with Parkinson's, they can be eligible earlier. They can be eligible, even before they develop any cognitive decline that might happen along with their Parkinson's, or if they want to start making plans, we can certainly help them with that. And so with that, we want to make sure that you have an assessment by yourself as the MRP, a second assessor who may be the prescriber if you're not willing to be the provider for MAiD. And then if you need a consultation, if she's been to the say a neurologist in the last number of years, you can go back to the neurologist that saw her, see if they wish to see her one more time to see if there's anything more that can be done to support her, to give her any improvement in her quality of life. Or if they've done everything that's acceptable to the patient and there's nothing more, then you can proceed on with a MAiD assessment for sure.
Thanks, Grace. This is Rose. Sorry for not coming on the
That's okay.
microphone
That's
earlier.
okay.
I wasn't being shy, but not sure how that conversation will be viewed by family. Is it offensive or is it insulting? I know she is always kind of bickering, I would say the right word, because she knows she's been told by the specialist what her prognosis is, what the options are, but generally she's not happy, so is family.
Yeah.
And when you're doing the virtual care, all that you hear is that I can't do anything, I can't do anything.
Yeah.
So when is the right time, or how do you bring it up, the options?
Yeah, I think, in a case like that, you might ask if you could have a meeting with family and start airing some of the concerns and some of the fears. And then just talk about what options there may be. There may be not too distant future, there may be a requirement for placement in long-term care because she's needing supports with her long-term with her ADLs, or maybe family caregivers are burning out and they're not able to care for her anymore. Pain is getting to be intolerable. Movement is, she's not having any quality of life. If she starts making wish to die statements, if she starts saying things like,
No, she didn't make those
Okay.
statements at all. And my problem is that I am empathizing with her. I know her personally very well, and she had a very rapid decline. So that's where the problem is.
Yeah, no.
If I can suggest too, I find that sometimes asking around what does end of life look like to you as your symptoms are progressing, what does end of life look like to you? Is there anything that you're afraid of? Is there anything that you're concerned about? Is there anything that you have questions about? And are you wanting to know all the options available in end of life? And that can include MAiD. Would you like more information about that? So there's ways that it can be addressed without it coming across as I have information about MAiD, here you go, to address it from more of a fear or any questions that that person might have.
Would you think the neurologists or the rehab people brought those topic up to her, rather than you being kind of an outsider just facilitating the Canada disability card and stuff like that? You're not actually participant in the care.
Are you the family physician?
I was a family physician, but she hasn't seen me for ages, and it's a kind of diverting all the attention from other resources and asking you to fill this form and fill that form.
Yeah.
And when you need information for the form, that's when you learn that how disabling it is.
Yeah. Well, I think in that kind of a case, I would request an in-person meeting. I definitely would like to get a better feel for how much suffering there is and visibly see it. And then, create a forum for bringing up the fears and what lies ahead. I think that's really important. And to be a person just filling out forms, that's not giving you the right kind of information. You're not in a place yet.
Yeah. That's how I felt,
For sure.
I don't have information to put on the form,
Exactly.
where the needs are.
Yeah, no, I think you need to get that meeting, and probably if you have access to a family caregiver, an adult child who seems to be the spokesperson or something, that might be helpful to connect with them to say, let's have a meeting and bring everybody together.
And
pretty big discussion to be had.
Yeah, and to
Thanks.
answer your question though, I personally don't hear a lot of specialists bringing up MAiD as a care option. It is entirely dependent on who that person is.
Mhm.
So I've learned over the years that I cannot make assumptions that it's going to come up, even when someone is very clearly making expressions of wanting to die.
Yeah.
Even then, I've learned that I cannot assume that someone is going to, that another practitioner is going to bring it up.
Except for oncologists. Oncologists seem to find a way of bringing it up, usually at the end of their whatever they have to offer. And at that point, they're in the position to have that conversation. I
Yeah,
hope
and
that was helpful, Dr. Kumar. So
Thank you. Thank
yeah, I
you.
have one more question here from Mary Lou. What's the timeline for decision to be approved for MAiD? So depending on track 1 or track 2, so if you've got somebody on track 1 and they've got a terminal condition and they're declining rapidly, you can have a MAiD assessment and provision done within a number of days, like 2 or 3 days. We can really rapidly process somebody who's suffering intolerably towards the end of life. Or if they have a few more days, it's always nice to have a few more days to be able to plan that, but that can happen. In track 2, there is a built-in safeguard. We have to have the 90-day waiting period. So from the beginning of the first assessment, whenever the primary care provider started talking about MAiD with the patient, that's day 1. Then from there is 90 days. And that during that period of 90 days, you need to get the second assessment done. You need to get an expert opinion. You need to provide counseling if required, palliative care if appropriate. All those things need to get done. So the 90 days comes up, and then after that, we can book a time for MAiD. So I hope that answers the question, but certainly those that want it in a short timeline can get that within a number of days. Does that answer your question, Dr. Montero? Yeah. Great. This is good. Anybody else? We still have some time. You don't have a microphone. Oh, too bad. Okay.
Grace, I'm wondering maybe if you could talk a little bit about how someone might become a MAiD assessor if they aren't one already.
That's really great. Thank you for the prompting. Because I forgot to do the poll questions. Anyway, so in the beginning, when we started the MAiD program in June of 2016, we sent out an email to all the divisions to ask if community practitioners would be interested in becoming a MAiD provider that's actually doing the provision. And we had a few, respond that they would, but not that many. We still have just a very small number of people that are Fraser Health wide provider group. And so we lean on family physicians, oncologists, other specialists that are very well known to the family, to the patient, to be the first assessors. And so that's why we asked the GPs if you would please do your first assessments for your patients. To do the assessment, not any training is really required. The form, if you look at it, it really basically goes through all of the legislated requirements, and you fill in all of the boxes and put in your diagnosis, and basically that meets the requirement for the legislation. And so the form itself is a way of ensuring that the patient meets eligibility criteria, and you tick off the box, yes, this patient meets all eligibility criteria, and you sign your name to that, and then you fax it to Tammy and her team. And then she finds the second assessor, contacts the patient, sets up the date for provision, etc. So being an assessor is pretty straightforward. You know your patient, you've already had the conversation or several conversations about this. And the form itself is basically acknowledging that you've done all those things, that the voluntary request was there. If it was reasonably foreseeable, their condition is this and that. They tick off boxes of cancers or end organ conditions or frailty, and you just write down what it might be, what conditions they're suffering from, and then sign that off. So that's the first assessment. And then the second assessment is done by the prescriber that we usually get through the coordination center. So that's how you become an assessor. And I'm hoping that some of you hoping all of you, if anybody from your practice wishes to have an assessment, feel comfortable going ahead doing that. And then to be a provider, that's what we call a prescriber. So you actually write the prescription for either the IV method or the oral protocol. And again, you send the form off to the coordination center, who sends it to the pharmacy that will have the medication available. And if one of you would like to become a prescriber, then we would have you go through a little bit of a webinar education to update you on all of the nuances of the legislation. And then we get you credentialed, and so that you're able to provide at all of Fraser Health facilities or in patients' homes in the communities. And so that's a process that would be interactive that I talk you through, and then you can actually become a Fraser Health MAiD provider or prescriber. So the assessor is one thing everybody should be doing for their own patients. And then prescriber is if you wish to take this on as part of your clinical practice. And we desperately need more prescribers, and anybody who's reducing their workload clinically, we'd be happy to recruit you to bring you on board as part of the team. And there's a message here from Dr. Lai or Dr. Lau. Quite often the family will ask for a patient to be started on an antidepressant as a possible means to defer them from vocalizing their death wish. Do you often come across this? Well, I myself I have not come across family asking for an antidepressant. If there was a concern that a patient is depressed, I would just go through what I would normally do, is do an assessment to see whether the patient has some symptoms that would indicate they're suffering from clinical depression, see if they're willing to take treatment for it, if they're able to take a medication that would interfere with any of their other medical conditions, go down that route. That it'd be kind of worrisome if a family were saying, can you use an antidepressant because I think my mom is wanting to die. Yeah, for sure you'd need to sort of really examine what the problem is. Is a person really depressed, or is a person suffering from existential suffering? They're feeling like they have no purpose in life and they're wanting to die because they have intolerable pain or some other condition, and they meet the criteria, then that's going down the MAiD route. You can go down the MAiD route and investigate to see whether they meet eligibility criteria, and as well start antidepressants if you feel that they could potentially benefit from antidepressants. There's no problem with doing that. So yeah, I would definitely consider, treating any underlying depression for sure. Hope that helped a little bit. So maybe let's do the poll questions after having gone through this very short presentation. Shall we do the poll questions and see if we made an impact? And
Sounds good.
okay,
I'll launch the first one. Did it pop up?
yes.
Okay, good. And then I will take your cue. You tell me how long you want it to, how long you'd like to keep it up there for, and then I'll just stop.
Okay, so let's stop there.
And then you should be able to see the results.
Yep, so we've got, do you have a table that gives you the exact percentage?
Yep. So the question being, how comfortable are you discussing MAiD with your patients? 50% of the respondents, of which there were 14, 50% said totally comfortable with it, no problems at all. 29% said somewhat comfortable, but I still have a bit of hesitation. And 21% said not at all comfortable with it.
Okay. So if anybody feels comfortable, of the group that said they're not at all comfortable, do you want to just type in what parts you're not comfortable with in the chat and see if we can have a discussion about that? Won't call you by name. I'll just, you just type in the question as to why you feel completely uncomfortable with bringing up the topic or talking about it with your patient. Right. Well, with religious beliefs and you have conscientious objection, we're happy that, you know, the legislation does not compel you to have to do this. It's just that we want to make sure that you're able to refer your patient to somebody who would be willing to talk about it. And it may be just giving them the number to the Care Coordination Center, because Tammy and her team would be happy to find people that they can actually do the assessment and take it over from there. But conscientious objection is something that for sure we have out there for sure. Right. And thinking that you want them to die. Yeah, no, you have to definitely feel comfortable in offering it as a patient-centered approach, a way of reducing their suffering, one of many things that are available. And, you know, if they are thinking that they would rather die than continue to suffer, there's information about it, and they can go on the website or they can read about it with the brochure, just making sure that it's not, yeah, it's not coming from you that you want them to die. Yeah, and you would discuss it if they bring it up. Yeah, I think it's a tricky thing, and I think it depends on how much you feel your understanding of their suffering and how much do you feel that they're truly wishing to have an end to their suffering.
We can move into question 2
Sure.
if you wanted. There we go. So are you aware of the changes in the new legislation for MAiD that came into effect in March 2021?
Yeah, so most people are aware of the change that came into place with
Yeah.
Bill C-7. So people with no reasonably foreseeable death, they do not have to have a condition that would shorten their lives per se in order to request MAiD. So we're talking about people with Parkinson's and MS, people that would have lived on for many, many years, but all of a sudden find they're suffering intolerably and they wish to have MAiD, they're now eligible. And, you know, people that have lived with quadriplegia since their car accident, may all of a sudden decide they don't want to live like this anymore, they're eligible for MAiD. So that's been a change. And then along with that, people that have reasonably foreseeable death, say they have cancer and they're taking higher doses of narcotics for pain control, even if they were to lose their capacity to consent at the end, they can actually have a waiver of that consent, so they can set a date and be assured that they can have the MAiD provision, even if they became delirious for whatever reason. So those changes came into place. And then also the fact that mental health conditions as a sole underlying reason for MAiD is now available and as of March of next year. And they wanted 2 years of deliberations to come up with safeguards, and that's coming into place. And so as of March of next year, people with mental health conditions only will be eligible for MAiD. And so there'll be more, I'm sure we'll discuss and we'll see more things in the media about that. So that's just to reiterate about Bill C-7. And then there was another question.
Yeah, I just launched. Are you comfortable doing MAiD assessments for your requesting patients?
Well, that's pretty good.
There's a good comment that it shouldn't be a yes or no question. On the survey evaluation, there's more options there, but I think you're right, Dr. Jackson. There's probably a bit of a gray area, which is one of the questions in the evaluation. There's more So strongly agree, kind of
Yeah.
comfortable, kind of not comfortable, that kind of thing. Yeah.
Yeah, that's true.
And then, so of the respondents, there's the results for question 3. And then I think there was one final question there.
Yeah.
There you go.
This is my attempt to recruit you guys to join our team.
And there's a comment in the chat there too, Dr.
Yes.
Yeah.
So nobody wants to join our team, Tammy. It's a very sad state of affairs. And then there was a comment, perhaps one doesn't have to agree with patient. Absolutely true. That's a really great point. And there's lots of discussions about cases where the provider does not agree with the patient. And in the Netherlands, we have a lot of patients or a lot of physicians, GPs, who feel that the patient is not suffering enough, that they haven't quite fulfilled the criteria for intolerable suffering, etc., and will decline the request for MAiD. And then the patients have a right to appeal, and they go to a specialty clinic. And at the specialty clinic, about 30% of those cases will get approved. And so there's different kinds of suffering that the specialists look at. And so even if it's not physical suffering, but the sort of psychological, the existential suffering, they'll go into that, or the fear of future suffering, all of those things. And so those that are doing a lot of assessments seem to have more of a comfort level with some of those cases. And so I think for now, if you feel uncomfortable with the patient, if you feel that you do not agree with the patient's request for MAiD, just make the referral to the coordination center, and we would have another look at those, and then they will be working with you, and you don't have to do the assessment, but we'll certainly have maybe another assessor have a look at the situation and go from there.
I had a message on my end here around any additional, Dr. Lal, regarding starting lines, for example, that one can bring up and how to broach this. So we had talked earlier about addressing end of life. I had one physician tell me one time that said, you know, right now we're focusing on your symptoms and managing that. And if at any point you would want to talk about MAiD, I am a safe person in which to do so. We're certainly focusing on maximizing your quality of life. And if at one point that is no longer acceptable to you, we can talk about end of life care options, which can include MAiD. So it's always making sure that it's coming across as an option, not something that, oh, you've been really struggling. I think MAiD is a good idea for you right now. There's very much that difference in that quality of that statement around providing the patient an opportunity to ask those questions. It does break my heart when we talk with people and they never knew that MAiD was an option, and they are very much progressed in their disease and very end stage. That is very difficult for us on our end because we're then scrambling and often we don't have the gift of time. And we have heard it that no one told them about MAiD and they didn't know that it existed. So I always say that you don't know what you don't know. So it's difficult to ask, which is also why just even handing a brochure can be helpful. And also if you have a particular patient as well, we're all clinicians on our end as well. So you can always phone us and say, this is my particular patient. I'm not quite sure how to bring it up. And we can have that conversation as well. And of course, always Dr. Park is available as well.
And I'm jumping for joy. Dr. Kumar says she would be happy to consider joining our team. So jumping up and down there, Dr. Kumar. So we'll connect, I'll connect with you by email and we'll get you some directions and figure out how we're going to do that. And we do get privileges for you, and it becomes a very easy process. So we'll do all of that. And then Dr. Singh Hai said, why are there so many MAiD cases on the island? We don't know exactly, except that I don't know if you remember these cases that were very high profile in the media, the cases that were actually in the forefront of the MAiD movement in Canada. What was her name again? The one with ALS. And then Kay Carter, of course, that the legislation started with. She was also from the island. Gloria, oh, what was her name that had the ALS right in the beginning? I can't remember. Anyway, so there have been a lot of cases in the media on the island, and it seems that people on the island are of the demographic. They're very autonomous people that went away to live on this island. They seem to have a say, they want to have their own say about, what happens at end of life. Autonomy is a very important value to them. Yes. So, and they're actually going to be doing a study. Sue Rodriguez, thank you. Yeah, she was the one with ALS. So they're actually going to do a study on the island to see what makes the profile of the islanders such that there is such a high, they are the leading region in Canada. 8%, 7 to 8% of their total deaths are by MAiD. And so it's a hopping place regarding MAiD. And Jan, yes, I've got your name and you don't have much time, but we'll let you go traveling for a while, but we'll come after you after that for sure. Thank you. Well, I think that's our time, isn't it, April?
Yes, you're right on time. We started at 6:05 and here we are at 7:04. So thank you so much for that. Just for all of the attendees, I'm going to be putting in the survey, the evaluation survey link into the chat. If anyone does not have access to the chat or you can't see it for a particular reason, we can send it out to you via email as well. It just takes a couple of quick, it's like 90 seconds, I think, to fill it out. So I'm just gonna put it in the chat right now. Evaluation survey, there you go. It'll take you right to your link. Please feel free to fill it in. That way it's quick and done. And then I just want to give a warm thank you to Dr. Park and Tammy for sharing their knowledge with us, helping give a little bit more information about what MAiD is. And then certainly for anyone who is interested in being an assessor, we'll be happy to link you up with Dr. Park and with Tammy. So I'll give you guys a couple of minutes to fill out the survey. And we'll say thank you to Dr. Park and Tammy for your time this evening. And Dr. Park, again, happy anniversary on your 40th.
Thank you. Thanks, everyone. It was great chatting with you tonight, and I hope to hear from you again soon. And I'll be in touch with a couple of you that
Lovely.
put your hand up. Thank you.
Thanks,
Bye-bye.
everyone.